Good morning to everybody. We'll start with defining which side branch should be protected and accessed. Actually, the clinical relevance is very important, which depends on the whole territory covered by side branch, total number of side branches, relative dominance, and vessel size and length. If we deal with small side branch, then there is no compromise on the outcome as shown by this study. And what happened normally to lose or to risk the loss of side branch during both simple stenting or complex stenting, that be provisional or two-stent procedures. Mainly, the problem is related to provisional stenting, and we know that today we all agree that provisional stenting should be taken very simple, that means in 3 steps: wiring, pre-dilating main vessel, then stenting main vessel pot. And if no compromise, the procedure is finishing here. If we have any compromise, we have to access side branch and then to open the strut to recover side branch. We have some protectors for side branch occlusion following accordingly to multivariate analysis. And we have also a score system to determine the risk of occlusion before starting the procedure. And the mechanism of side branch occlusion during bifurcation lesion interventions are carina shifting, or plaque shifting, or dissection, and sometimes also Vaspad. We have intravascular imaging predictors in IVUS. We have the distance from carina to opposite side of side branch, and the bifurcation lesion, that means the origin of side branch angle, can be determined mainly by longitudinal view of with IVUS, as well as the layered pattern and acute side branch in OCT can also be predictor for side branch occlusion. When side branch occlusion might occur? During pre-dilatation, during stenting main vessel, that means provisional stenting, or 2 stents, with any of these procedures, and mainly during pre-dilatation, or if you are starting a stenting main vessel with the 2-stent technique like TAP or T-stenting. And if missing any approach of these of 2-stents technique can determine the occlusion of side branch. Now we have active techniques to protect side branch. First, the most simple and the oldest is jailed wire, then jailed balloon, jailed microcatheter modification, and stenting side branch, shifting from provisional to 2-stents technique. Now, the jailed wire involved leaving the wire in side branch jailed by the stent after pre-dilatation, during pre-dilatation and during stenting. But this might have some problem retrieving the wire after stenting with the damage of the wire or fracture of the wire, leaving it in side branch. And this have been reported in some cases, as well as 2 wires technique, that means putting 2 wires instead of 1, but this again still associated with some complication like the fracture of the side branch. Then jailed balloon, semi-compliant balloon is jailed by the stent during stenting. After stenting, the jailed balloon is inflated and retrieved, and then pot in proximal main vessel stenting, and this will give the security to recover side branch. This is what is done, putting the stent with the jailed wire. Then after, this is what happened, and this is corrected by inflating the balloon, the jailed balloon, and this is coming back. Now, the inflation pressure is not affecting the recovery of side branch. What is important, or what is more risky, is the presence of calcification at the ostium side branch, or the lesion length on side branch more than 9 millimeters. Possible complication of jailed balloon is the deformation of the stent retrieving the balloon, the jailed balloon after inflation side branch, and this have been reported in some cases. There are so many modifications of the jailed balloon technique. This is the modified jailed balloon that been inflating both the stent balloon and the jailed balloon together, and retrieving then the jailed balloon and without any other approach. And this have been reported in 2019 and have been modified by jailing the balloon, again, inflating separately both balloons, inflating simultaneously. That means doing kissing balloon, the jailed balloon with the stent, retrieving the jailed balloon, and this will be, the procedure will be completed, recovering the side branch. Again, this is what is called the balloon stent kissing technique, which was modified, adding a pot after retrieving the jailed balloon. So every modification ported some new step in the jailed balloon technique. And double kissing, that is the last modification, double kissing inflation. That means inflation stent balloon with the jailed balloon, and then after this, inflating, doing another kissing with distally to the origin of the side branch with the jailed balloon again, finishing with pot, and this will ensure more the recovery, the complete recovery of side branch and protection of side branch. Active side branch with protection with microcatheter. This has been reported in order to ensure the access to side branch with a wire, and then complete with ballooning. And this one example, particularly in 3 trifurcation, you can use jailed balloon and microcatheter together, and then this will allow again the access of both branches coming from the trifurcation. In the 17 expert consensus document, all what I have exposed before have been summarized in this figure. And what is important is sometimes that the access, if you do not leave any wire, anything inside branch, then the access can be very difficult, particularly in challenging anatomy. And of course, you should have some experience in how to access side branch before starting your procedure, in order to be sure that you having a wire that offers you a different solution to recover the side branch if lost. These techniques are balloon backstop, reverse wiring technique, double lumen catheter, venture catheter, angulated microcatheter, and steered deflecting tip wires. Starting with the balloon backstop technique, inflating a balloon distally to the bifurcation, then going with the wire. The wire will be stopped by the inflated balloon. If it is curved adequately, then you can access side branch even if it is challenging, like in this case. The second is reverse wiring, and this depends on the shaping of the wire. There are two modalities, hook technique, and that shape, the J-tip shape, or a hairpin bend shape. It depends on how much is the angulation, how much is the challenging origin of side branch. And again, this reverse wiring, after shaping adequately the wire, will gives you the possibility to get in the side branch. The other thing is the double lumen catheter, which allows shaping the wire adequately the anatomy, and the second exit of this microlumen can permit you to access the side branch with adequate angulation of the tip of the guide wire. And the venture wire, which is deflectable catheter, but it's very at least needs some experience to be used. It's not that easy, that much easy, and to move and to navigate into the difficult anatomy particularly. So with deflecting the tip, you can adequately deflect it to orientate the tip to the origin of side branch and to access side branch with the wire. More easy to the use of angulated microcatheters, which is more recent than the last one, and which is a dual coil design, provides excellent torque response with various angulation till 90 degree, and this it's positioned in front of the side branch and then accessed by the wire. And finally, the steered deflecting tip guide wire. This again can permit the angulation or the changing the curve accordingly to anatomy, by deflecting tip of the wire. In case of any doubt about side branch compromise, at least leave a wire in it. A jailed wire in side branch offers different solution to recover side branch every time. So my final remarks that clinically relevant side branches should be protected during main vessel stenting for the treatment of bifurcation lesion. In provisional stenting, side branch compromise can occur even if it is not expected. When you ask yourself the question, should I protect the side branch? The answer is always yes, protect it. That means you have some doubt about. Jail wire, jail balloon, all the systems or techniques we have mentioned before can rescue the side branch. There is no gold standard approach for side branch active protection during bifurcation intervention. In some difficult cases, some modification to the previously described approach can be done accordingly to the operator experience and creativity based on reported cases or small cohorts. Learn always from experience of others and share yours. Thank you very much for your attention.